If you have had a heart attack, someone, a doctor, a physical therapist, a family member, a well-meaning friend, has almost certainly told you that you need to exercise, that getting active again is part of your recovery, that sitting still is dangerous. And they were right. Exercise after a heart attack, done correctly, is one of the most powerful tools in cardiac rehabilitation. It reduces the risk of a second heart attack. It strengthens the heart muscle. It improves quality of life in ways that no medication fully replicates. But here is what that same doctor, physical therapist, or family member almost certainly did not tell you. There is one specific category of exercise that looks healthy, feels like you are doing something productive, is widely recommended in general fitness culture, and is performed every single day by millions of older adults who have had heart attacks. And for that population, it is not just counterproductive. It is directly dangerous. In certain individuals, it can trigger a second cardiac event. And the reason it is dangerous has nothing to do with effort level or intensity in the way most people understand those terms. It is dangerous because of the specific mechanical stress it places on a heart that has been structurally altered by a cardiac event, a heart that is not the same organ it was before the attack, and that does not respond to certain types of physical demand the way a healthy heart does. I want to be very clear about what this video is and what it is not. This is not a message to stop exercising. This is not a message that seniors who have had heart attacks should be afraid to move. Fear-based inactivity after a cardiac event causes its own serious harm: deconditioning, blood clots, depression, and a dramatically increased risk of a second event. This is a message about one specific exercise category that carries documented risk for post-infarction patients, why it carries that risk at the biological level, and what to replace it with so that you get all the benefit of an active recovery without the danger. Stay through this entire video. The explanation of why this particular exercise is dangerous requires context, because without understanding what a heart attack does to the structure of the heart, the risk will not make sense. And without it making sense, you will not take it as seriously as you should. And drop a 1 in the comments right now if you or someone you love has had a heart attack. I want to know how many people this directly applies to today. To understand why one specific type of exercise is dangerous after a heart attack, you first need to understand what a heart attack actually does to the heart. Not in the vague general terms most patients receive, but in precise structural terms that explain what you are now working with. A heart attack, the medical term is myocardial infarction, occurs when blood flow through one of the coronary arteries is blocked long enough that the heart muscle cells in that artery's territory die from oxygen deprivation. Those cells do not recover, they do not regenerate. The human heart, unlike the liver or the skin, does not replace dead muscle cells with new ones. Instead, over the weeks and months following a heart attack, the dead muscle tissue is replaced with scar tissue, a process called myocardial fibrosis. This scar tissue is not dead weight, it serves a structural purpose. It prevents the weakened area of the heart wall from rupturing under the pressure of each heartbeat. But it is also not muscle. It does not contract. It does not contribute to the pumping function of the heart. It is stiff, where living heart muscle is compliant. It is passive, where living heart muscle is active, and its presence in the heart wall fundamentally changes how that wall responds to the increased pressure demands of physical exertion. In the months immediately following a heart attack, typically the first 6 to 12 weeks, the scar tissue is still forming and is at its most vulnerable. Cardiologists call this the remodeling period. During this phase, the infarcted region of the heart wall is undergoing active structural changes. Cells are dying, inflammatory processes are clearing debris, fibroblasts are laying down collagen to form the scar. The mechanical integrity of the heart wall in that area is at its lowest. But even after the scar has fully formed, which typically occurs by 3 to 6 months post-infarction, the heart's functional capacity has permanently changed in ways that matter for exercise prescription. The ejection fraction, the percentage of blood that the heart pumps out with each contraction, is often reduced. The heart's ability to increase output rapidly in response to sudden demand is diminished. The electrical conduction pathways through the heart, which coordinate the precise timing of each chamber's contraction, may have been disrupted by the infarction, and the remaining healthy heart muscle is now working harder to compensate for the portion that can no longer contribute, which means it is operating closer to its functional ceiling under conditions that would have been well within its reserve before the attack. This is the heart you are exercising, not the heart you had at 60, not the heart you had before the event. A structurally and functionally altered organ with reduced reserve, an area of non-contractile scar tissue, potentially disrupted electrical pathways, and a compensating muscle that has less margin for error than it did before. Every exercise decision after a heart attack needs to be made with this reality as its foundation. The exercise category that poses the greatest and most specific danger to seniors who have had a heart attack is heavy resistance training, specifically any exercise that involves lifting, pushing, or straining against significant resistance with sustained muscular effort and breath holding. This includes heavy weightlifting with dumbbells or barbells. It includes the chest press machine, the leg press machine, and the shoulder press machine set at resistance levels that require maximum or near maximum effort. It includes certain yoga poses held under strain. It includes heavy gardening tasks, digging through hard soil, moving large bags of mulch, pulling out deep-rooted plants with full-body exertion. It includes moving furniture. It includes any activity where you find yourself holding your breath, bearing down, or straining, even activities that do not look like exercise to most people. The specific physiological mechanism that makes this dangerous is called the Valsalva maneuver, and understanding it is the key to understanding this entire warning. When you strain against a heavy resistance, when you lift something very heavy, push hard against something, or hold a difficult position under load, your body instinctively closes the glottis, the opening at the back of your throat, and increases pressure in the thoracic cavity. This pressure increase is the Valsalva maneuver. It happens automatically. You do not decide to do it. Your body does it to stabilize the trunk and protect the spine during heavy exertion. Here is what the Valsalva maneuver does inside the cardiovascular system of a post-heart attack patient. During the strain phase, the increased thoracic pressure compresses the large veins, returning blood to the heart. Less blood enters the right side of the heart. The heart has less to pump. Blood pressure drops momentarily. The heart rate spikes abruptly in response to compensate. In a healthy heart, this is a brief and manageable sequence. In a post-infarction heart with reduced ejection fraction, disrupted electrical pathways, and a scarred non-contractile region, this sequence can trigger a dangerous arrhythmia, an abnormal heart rhythm, or in severe cases, a second myocardial infarction. When the straining ends, when you release the load, set down the weight, or come out of the strained position, the compressed veins suddenly release their stored blood volume back into circulation. A large bolus of blood rushes into the right side of the heart and then immediately into the left. The sudden increase in cardiac filling pressure creates a rapid spike in blood pressure. In a healthy heart, this is handled smoothly. In a post-infarction heart, where the left ventricle is already operating at reduced efficiency, this sudden pressure spike can cause acute cardiac stress that triggers arrhythmia, or, in vulnerable patients, precipitate another event. This is not theoretical. A study published in the American Journal of Cardiology documented that Valsalva-inducing activities, specifically heavy resistance exercise and heavy lifting, were among the most frequently identified triggers in the hours preceding recurrent myocardial infarction in post-infarction patients. The American Heart Association specifically lists heavy resistance exercise as a category requiring medical clearance and supervision for post-cardiac event patients. And the European Society of Cardiology's guidelines on exercise in patients with cardiovascular disease explicitly caution against high-intensity static exercise involving the Valsalva maneuver in the post-infarction population. The reason this warning is so important for seniors specifically, rather than for all post-heart attack patients, is that adults over 65 are the most likely to encounter heavy resistance demands in the context of daily life rather than a gym. Moving a heavy piece of furniture to vacuum behind it, carrying multiple bags of groceries upstairs, pulling a stuck window open, lifting a heavy grandchild repeatedly, digging a garden bed. None of these feel like exercising. All of them involve exactly the kind of sustained muscular strain and Valsalva response that post-infarction cardiology guidelines warn against. If you have had a heart attack and you have been told that exercise is important, and it absolutely is, the question that was probably not answered clearly enough is, which exercises, at what intensity, and with what specific limitations? That is the question this video is answering. Beyond heavy resistance training, there is a second category of exercise that post-heart attack seniors need to understand clearly. Any activity that involves a sudden, abrupt escalation from rest to intense effort without a transition period. This means sprinting from a standing start. It means performing high-intensity interval training, HIIT workouts, that involve rapid alternation between intense effort and rest, which are extraordinarily popular in general fitness culture and are being increasingly marketed to older adults as time-efficient exercise. It means competitive sports that involve sudden all-out sprinting or explosive effort, tennis serving, pickleball sprints to the net, racquetball, anything that requires an abrupt surge of maximum or near maximum cardiovascular output. The reason this is dangerous is separate from the Valsalva mechanism and relates to a different physiological vulnerability in the post-infarction heart. The heart increases its output during exercise through two mechanisms simultaneously. The first is increased heart rate. The heart beats faster to deliver more blood per minute. The second is increased stroke volume. The heart fills more completely with each beat and ejects more blood per contraction. Both mechanisms require that the coronary arteries, the arteries feeding oxygen-rich blood to the heart muscle itself, can increase their own blood flow to meet the higher oxygen demand of the working cardiac muscle. In a post-infarction patient, the coronary artery that caused the original event may have been stented or bypassed, but it was diseased for a reason, and that underlying tendency toward atherosclerotic plaque formation typically affects multiple vessels. The coronary circulation of a post-heart attack senior is not a clean, fully open vascular system. It is a system where one major event has already occurred and where other vessels may carry their own degrees of narrowing. When exercise intensity escalates suddenly, the demand on the coronary circulation spikes abruptly. If narrowed coronary vessels cannot increase blood flow fast enough to meet that demand, a region of heart muscle is briefly starved of oxygen, a condition called demand ischemia. In most cases, this is brief and resolves when the intensity drops. But in a structurally compromised post-infarction heart, this brief ischemic episode can destabilize vulnerable coronary plaque in adjacent vessels, trigger arrhythmia, or in vulnerable individuals, produce another acute coronary event. Cardiac rehabilitation programs, formal, supervised exercise programs specifically designed for post-heart attack patients, are structured precisely to avoid both of these dangers. They include a gradual warm-up that allows the coronary circulation to increase blood flow gradually before intensity rises. They use resistance levels well below the threshold for Valsalva. They monitor heart rate continuously to ensure the patient stays within a prescribed range. They teach patients to recognize warning symptoms and stop immediately, and they are supervised by healthcare providers who are equipped to respond if something goes wrong. If you have had a heart attack and you are not currently enrolled in a formal cardiac rehabilitation program, that enrollment should be your immediate priority. Medicare covers cardiac rehabilitation for qualified patients, meaning any Medicare beneficiary who has had a heart attack within the preceding 12 months qualifies for coverage of up to 36 sessions of supervised cardiac rehabilitation. Your cardiologist can provide the referral. The program that most insurance covers is typically through a hospital-affiliated rehabilitation center. Call your cardiologist's office this week and ask specifically, "Am I eligible for cardiac rehabilitation and can you provide a referral?" Now that you understand what to avoid and why, let me give you the complete picture of what the evidence supports as safe, beneficial, and genuinely protective exercise for seniors after a heart attack. Because the goal is not inactivity. The goal is the right activity, performed correctly, with appropriate monitoring and progression. The single most evidence-backed exercise modality for post-heart attack recovery in seniors is moderate intensity, continuous aerobic exercise. In plain terms, this means walking, not slow shuffling, not a leisurely stroll, but a purposeful, steady-pace walk that elevates your heart rate to a moderate level and sustains it there for the duration of the session. The target heart rate range for post-infarction aerobic exercise is typically 50 to 70% of your maximum heart rate, calculated by your cardiologist or cardiac rehabilitation team, based on your specific post-event stress test results, not a generic formula. For most post-heart attack seniors, this means walking at a pace where you can hold a conversation but would not be comfortable singing, what exercise physiologists call the talk test. If you cannot speak in full sentences, you are working too hard and need to slow down. If you could comfortably sing, you can increase your pace slightly. The Garmin VivoSmart 5, available on Amazon and at Best Buy for approximately $130, is a wrist-worn fitness tracker that monitors heart rate continuously during exercise and allows you to set heart rate alerts, meaning it will vibrate to notify you if your heart rate exceeds a ceiling you set with your cardiologist. This kind of real-time monitoring removes the guesswork from moderate intensity exercise and provides objective data to bring to your follow-up appointments. The Apple Watch Series 9, available at Apple stores and Best Buy, offers the same continuous heart rate monitoring with the addition of irregular rhythm notifications, an FDA-authorized feature that detects atrial fibrillation, one of the most common post-heart attack arrhythmias. Either device is a meaningful investment for a post-infarction patient who is returning to independent exercise. The recommended walking program for post-heart attack seniors, based on the American Heart Association's guidelines, begins conservatively. In the first 4 weeks after hospital discharge, with physician clearance, 5 to 10 minutes of easy walking per session, twice daily, with rest as needed. By weeks 8 to 12, working toward 20 to 30 continuous minutes at moderate pace, 5 days per week. By 6 months post-event with no complications, 30 to 45 minutes of moderate intensity walking 5 days per week is a reasonable and well-supported goal. Light resistance training, and this is an important distinction from heavy resistance training, is not contraindicated after a heart attack. It is beneficial. The difference is in the resistance level. Light resistance training means using weights or resistance bands at a level where you can complete 15 to 20 repetitions without straining, without holding your breath, and without any sensation of maximum effort. This is not a workout that feels hard in the way heavy lifting feels hard. It is a workout where the muscles are stimulated enough to maintain mass and function, but the cardiovascular demand is steady and moderate rather than spiked and intense. The specific equipment I recommend for home light resistance training in post-heart attack seniors is resistance bands rather than dumbbells. TheraBand resistance bands, specifically the yellow and red resistance levels, which represent light and medium resistance, are available at CVS, Walgreens, Target, and Amazon for approximately $15 to $20 per set. Resistance bands are preferred over dumbbells for post-cardiac patients for a specific reason. The resistance is distributed smoothly through the full range of motion rather than requiring a sudden initial force to overcome inertia, which reduces the tendency to hold the breath and strain at the start of a movement. TheraBand resistance band exercise programs specifically designed for post-cardiac patients are available through the American Heart Association's website at no cost. Swimming and water-based exercise deserve specific mention because they are among the best evidenced post-cardiac exercise modalities for seniors. The buoyancy of water reduces joint stress that limits land-based exercise in many older adults. The hydrostatic pressure of water gently compresses the peripheral vasculature, which reduces the work the heart must do to return blood from the extremities. A direct cardiovascular benefit, and the aerobic demand is easily regulated through pace. Warm water pools at a temperature of 82 to 86 degrees Fahrenheit are specifically recommended for cardiac patients because warm water vasodilates the peripheral vessels, reducing vascular resistance and the cardiac work required at any given exercise intensity. The YMCA operates warm water pool facilities in most major U.S. cities and specifically offers cardiac-friendly aquatic exercise programs at many locations. Call your nearest YMCA and ask whether they offer silver sneakers or cardiac rehabilitation aquatic classes. Tai Chi has accumulated meaningful clinical evidence as a post-cardiac exercise modality and deserves more attention than it typically receives in Western cardiology practice. A meta-analysis published in the European Journal of Preventive Cardiology found that Tai Chi practice in post-cardiac patients was associated with significant reductions in systolic blood pressure, improvements in exercise tolerance, and reductions in psychological distress, a major underaddressed factor in cardiac recovery. The movements of Tai Chi are slow, continuous, and performed at low resistance levels that do not approach the Valsalva threshold. The balance and body awareness training carries significant fall prevention benefit for seniors, and the meditative quality of the practice addresses the anxiety and depression that accompany cardiac events in a substantial proportion of older patients and that, left unaddressed, independently increase the risk of a second event. Tai Chi classes for seniors are available at most YMCAs, at many community centers, and through online programs. The Dr. Paul Lam Tai Chi for Health program, available through the Tai Chi for Health Institute website, is specifically designed for people with chronic health conditions and has been evaluated in clinical trials of cardiac patients. No conversation about exercise after a heart attack is complete without this section, because even well-designed, appropriately paced exercise carries some risk in post-infarction patients, and knowing when to stop is as important as knowing how to start. The following symptoms during exercise in a post-heart attack patient are not warning signs to slow down and monitor. They are signals to stop immediately, sit down, and call 911 if they do not resolve within 2 minutes. Chest pain, pressure, tightness, or discomfort of any kind during exercise. This includes discomfort that radiates into the jaw, the left arm, the back, or the upper abdomen. Chest discomfort during exertion in a post-infarction patient is demand ischemia until proven otherwise and requires emergency evaluation every single time, without exception, regardless of how mild it seems. Sudden, severe shortness of breath that is disproportionate to the intensity of exercise you are performing. If you are walking at a moderate pace and suddenly feel that you cannot get enough air in a way that feels dramatically different from ordinary exertion breathlessness, stop immediately. Lightheadedness, dizziness, or a feeling of near fainting during exercise. This can indicate an arrhythmia, a drop in cardiac output, or orthostatic hypotension. Sit down. Do not try to walk it off. Palpitations. A feeling that your heart is racing, fluttering, skipping, or beating in an irregular or unusually forceful pattern. Palpitations during exercise in a post-heart attack patient can represent atrial fibrillation, ventricular ectopic beats, or more serious arrhythmias. Stop and sit. If palpitations continue for more than 2 minutes or are accompanied by any other symptom, call 911. Unusual fatigue that is dramatically out of proportion to what you are doing. Fatigue that feels different from ordinary exercise tiredness, more like a systemic exhaustion that comes on suddenly. This can be a symptom of reduced cardiac output. Nausea during exercise that was not present at the start of the session. Any of these symptoms require you to stop exercise, sit or lie down in a safe position, and either call 911 or have someone with you call 911 if symptoms do not fully resolve within 2 minutes. Post-heart attack patients should not exercise alone until cleared to do so by their cardiologist. For the first several months of independent exercise after a cardiac event, exercising with another person present or at a facility where staff are present and trained is a genuine safety recommendation, not an overcautious suggestion. Keep a small card in your wallet listing your cardiologist's name, your primary care physician's name, and any current medications and doses. In the event of a cardiac emergency during exercise, this information helps emergency responders provide appropriate care immediately. Everything in this video is general information based on published cardiology guidelines and research. It is not a substitute for personalized medical guidance from the physician who knows your specific infarction size, your current ejection fraction, your coronary anatomy, and your medication regimen. Before you begin any independent exercise program after a heart attack, you need answers to 5 specific questions from your cardiologist. The first question is, what is my current ejection fraction, and what does that mean for my exercise intensity ceiling? Ejection fraction, the percentage of blood pumped out of the left ventricle with each heartbeat, is the single most important number in post-cardiac exercise prescription. A normal ejection fraction is 55 to 70%. A mildly reduced ejection fraction is 41 to 54%. Heart failure with reduced ejection fraction is classified at 40% or below. The lower your ejection fraction, the lower your safe exercise intensity ceiling, and your cardiologist should give you a specific heart rate range rather than general guidance. The second question is, has my most recent stress test or imaging shown any exercise-induced ischemia, meaning any region of my heart that shows reduced blood flow during physical demand? The answer to this question determines whether you have coronary vessels that are adequately treated or whether there is residual disease that limits what physical demand your heart can safely accommodate. The third question is, do I have any arrhythmias that affect my exercise prescription? Post-infarction arrhythmias, including atrial fibrillation, ventricular ectopic beats, and heart block, each carry specific implications for exercise safety and heart rate monitoring. The fourth question is, are any of my current medications likely to affect my heart rate response to exercise? Beta blockers. Medications like metoprolol, sold as Lopressor and Toprol XL by AstraZeneca, and Carvedilol, sold as Coreg by GlaxoSmithKline, blunt the heart rate response to exertion, meaning your heart rate will not rise as predictably with exercise intensity as it would without these medications. This makes standard target heart rate calculations less reliable and requires your cardiologist to adjust your exercise heart rate targets specifically. The fifth question is, am I eligible for formal cardiac rehabilitation, and will you provide a referral? If your cardiologist has not already offered this referral, ask directly. Cardiac rehabilitation reduces the risk of cardiovascular death in post-heart attack patients by 26%, according to a Cochrane review of over 14,000 patients. It is one of the most evidence-backed interventions in all of post-cardiac care, and it is significantly underutilized. Studies consistently show that only about 30% of eligible post-heart attack patients actually attend cardiac rehabilitation, often because the referral was never made or the patient did not understand what it involved. The recovery from a heart attack is not simply a matter of time. It is a matter of making the right decisions about medication, about diet, about stress, and about exercise during the months after the event, when the heart is remodeling and when the choices you make have their greatest effect on what the next decade of your life looks like. Exercise is not optional in that recovery. It is essential, but it is essential in its safe form. Walking, light resistance, water exercise, tai chi, supervised rehabilitation, and dangerous in its unsafe form. Heavy resistance, Valsalva-inducing strain, sudden high-intensity bursts, and unsupervised independent exercise before medical clearance. You survived something that kills hundreds of thousands of Americans every year. The work you put into your recovery now is the most direct investment you can make in the decades still ahead of you. Tell me in the comments, have you had a heart attack, and did your cardiologist give you specific exercise guidance? Was cardiac rehabilitation ever offered to you? Your experience is exactly what other people in this community need to hear.